for us as clinicians, it is one of those parameters where measurement has significant implications. What do I mean by that? So, I very briefly talked about the lipoprotein little a being an LDL particle that is attached to a protein called apolitile. Now, this protein, because of its structure, can have multiple residues of some units that can really play havoc as far as the measurement is concerned. So there are assays for lipoprotein little a, and that is one of the real issues with this field.
You're listening to Parallax from Radcliffe Cardiology in association with makeadent.org. Here is your host, Ankur Kalra, MD.
Hello, everyone. Welcome to another episode of Parallax. Just before we begin, I wanted to thank all the listeners for making Parallax what it is today. Feedspot.com came out with their rankings of 15 best cardiology podcasts on September 1, and Parallax was ranked at 2. So this would not have been possible without the listenership and obviously without the stellar guests that we have on the show who teach us and mentor us and talk to us about how to advance a career in cardiovascular medicine, and also talk to us about the latest science, which I think is a good segue for me to introduce my speaker on the show today. My speaker today is someone who is very special to me, someone who I consider family, someone whom I've known for as far as it dates back. I think it's getting to be close to 10 years. I was a second-year cardiology fellow when I first got to know him, and had a really good opportunity with him to do some good work in India with the American College of Cardiology. He has since gone on from strength to strength and has mentored so many of us, and is professor of medicine at Baylor College of Medicine. Also runs their fellowship program in cardiovascular diseases, and has taken on a well-deserved and an exciting role as Vice Provost of Research at Aga Khan University, starting in a few months. So with that introduction, and he wears so many hats that it's impossible for me to describe all that he does in this introduction for the podcast. But with all due respect, Dr. Virani, welcome on the show, and thank you so much for doing this for us.
Thank you so much, Ankur, and it's always a pleasure to be working with you on any kind of scholarly activity, whether that's writing a paper, doing a podcast. So I'm all excited.
The feelings are mutual. So, Dr. Virani, I could not think of anyone better than yourself to, discuss this topic, which is becoming extremely important in cardiovascular medicine. And that is the topic of Lp(a). Now, a lot of us, start rolling their eyes when they hear about Lp(a) because it just feels like a conundrum to so many of us. And I need your help here in simplifying the concepts around Lp(a). So, for the cardiologists who are listening and also for the patients who are listening, what is Lp(a)?
Sure. So let's start out by understanding what Lp(a) is. So simply stated, it is like an LDL particle that we have. So it's an LDL particle, but attached to that LDL particle is a small protein called apolitile. So it's an LDL particle along with a protein molecule called apolitile. So it has all the things you would expect associated with LDL. For example, it increases one's risk of atherosclerosis, as LDL does. But in addition, it has a few other properties because of this special protein that we have, which is apolitile, as I mentioned. This particular protein, apolitile, we do not know the exact role it plays in humans, but it has a very high structural homology with plasminogen. Now, some people think that because of this role, Lp(a) may be the missing link between atherosclerosis and thrombosis, although I will caution you that the associations that we have seen for atherosclerosis or atherosclerotic cardiovascular disease, as well as calcific aortic stenosis, which we can talk about, are much more robust compared to the associations with thrombosis-related complications. I think there's some data in kids with arterial thrombosis, but venous thrombosis, the data are not as strong. So it is LDL along with this apo-a protein. I told you that it increases the risk of atherosclerosis, perhaps thrombosis. Now, Lp(a) molecule has a very high content of oxidized phospholipids, and as we all know, that oxidized phospholipids really make any particle extremely atherogenic. They may increase the propensity that that particle is going to be picked up by macrophages quite efficiently. And that again makes Lp(a) extremely atherogenic. Some would say that, per millimole, Lp(a) may be a little more atherogenic compared to LDL particles. The other thing that we're learning about lipoprotein A, and I think we've known this now for quite a few years, is that it has some procalcific properties as well because of some enzymes that are present. Perhaps it is also related to oxidized phospholipids as well. So there's a very robust association between high levels of lipoprotein A and calcific aortic stenosis. So to summarize, this is a particle that is associated with atherosclerosis, all forms of atherosclerosis, so ischemic heart disease, peripheral arterial disease, ischemic strokes. It's also associated with calcific aortic stenosis, and perhaps in kids there is some association with arterial thrombotic strokes as well. So I hope that clarifies a little bit about what lipoprotein A is and what are the main associations that we all as clinicians should be aware of.
Yeah, no, it absolutely does. I mean, also a wide spectrum of ages that are, affected, from childhood all the way to adulthood and even elderly. I mean, senile calcific aortic stenosis, as we know, is, one of the most common valvular conditions that we see in the geriatric cardiology population. Certainly both atherosclerosis and thrombosis, form the vast majority of cardiovascular disease practice for any cardiology clinic. So it's enlightening that Lp(a) has been associated with both pathogenic mechanisms. I'm going to ask you a follow-up question to this, and this sort of raises my curiosity as well, and that is, if this particle is attached to the LDL molecule, like you taught us, lowering LDL should also lower Lp(a). Is that right?
Not exactly. It's interesting. We can talk about the therapies, later on once we spend some more time into some of the associations and whether those are causal or not. But in terms of therapies, we do not know a lot about this. This is a very enigmatic molecule. So we don't know exactly. We have some ideas as to where it is produced in the liver. Some people would think that it's assembled in the space of DISI, but how it is removed is not very clear. So, for example, we know statins lower LDL cholesterol, statins lower ASCVD risk, but statins do not lower lipoprotein A. In fact, it remains a little controversial that statins may raise Lp(a) levels a little bit. Despite that, of course, we do use statin therapy in patients who may have elevated Lp(a) levels. On the other hand, so statins increase LDL receptors, but they do not lower lipoprotein A. PCSK9 inhibitors increase LDL receptors, but at the same time, they lower lipoprotein A by 20 to 25%. So again, you can see both the lipid-lowering agents increase LDL receptor density, but one does not lower Lp(a), one does. Niacin lowers lipoprotein A, but we know that it does not reduce ASCVD events based on multiple randomized trials that we've had, so it's not recommended. And then, of course, we have specific therapies that lower Lp(a) that we can talk about a little bit later. So it's very interesting to know that some things that lower LDL cholesterol also lower lipoprotein(a) levels, and some therapies that we have that do that do not actually lower lipoprotein(a). So there's a lot that we need to learn about this particular lipoprotein.
Yeah, which, I think it's a great segue to my next question, and that is that well, I think it's a two-part question, and I can certainly repeat the second part when we get there. But the first part is, in what patient population or in what patient subset would you think of ordering Lp(a)? That's the first segment of this two-part question. The second segment is when you look at Lp(a) in comparison with some of the other markers of atherosclerosis that are well described in the literature, for example, calcium score, or referred to as CAG score, high sensitivity CRP, and just the office-based lipid panel. Where do you place Lp(a) in the algorithm, if you may, for lack of a better word, when you are risk stratifying patients in whom you think Lp(a) will be of incremental value in prediction of risk for either a first event or future events?
Sure. So that's a very interesting question. Let me take your second question first, because that will then allow us to segue into your first question that you asked. So a few things about Lp(a) that we know. First, that based on Mendelian randomization studies, it appears to be a causal risk factor. So it's not just a risk marker. It seems to be in the causal pathway of atherosclerosis. So that's one very important thing about lipoprotein(a) that we've learned in the last, I would say, decade and a half, where when we look at these Mendelian randomization studies, they would imply that Lp(a) is in the causal pathway of atherosclerosis. So that's number one. The second is that if we look at some of the more recent studies, the risk appears to be continuous. So at any Lp(a) levels, you have a higher risk of atherosclerosis compared to lower levels. But of course, we use these cutoffs because, these risk factors are continuous, like LDL cholesterol is continuous, but we use cutoffs for various decision making that we do just to make it easier on us. But based on the recent studies, the risk with lipoprotein(a) levels is continuous, and it's been shown in all ethnic groups, whether we look at Caucasians, African Americans, South Asians, Hispanics. In all of these ethnic and racial groups, as well as people who live in various geographies, it appears to be associated with atherosclerotic cardiovascular disease. So those are important things that we need to know. The other thing we need to know that more than 90% of lipoprotein(a) levels are genetically determined. So as opposed to some lipid parameters or some other markers which can be affected too much by lifestyle and other things that are going on, for most part, lipoprotein(a) levels are mediated by genetics. And very small proportion of the lipoprotein(a) concentration is dependent on other factors, for example, lifestyle-related factors. So very early on, Lp(a) levels are very reliable in terms of knowing where this person stands in terms of their lipoprotein(a) risk. The second aspect, when we talk about risk of lipoprotein(a), it's very interesting that there is a very wide difference in terms of what the levels are in various racial and ethnic groups. For example, African Americans generally have the highest lipoprotein(a) levels. After that, you have South Asians, then you have Caucasians or whites, and then Hispanics and East Asians have some of the lowest levels of lipoprotein(a). So there's a very wide ethnic as well as racial distribution of lipoprotein(a) levels, which is again very well controlled by genetics. Although in all of these ethnic groups, there are various studies that show that lipoprotein(a) is associated with an increased risk of atherosclerosis. There's also data, so this is primary prevention, what we've talked about up till now, But when you look at secondary prevention trials, whether you look at statin trials or PCSK9 inhibitor trials, what we see is that despite control of LDL cholesterol, lipoprotein little a is one of those parameters that can also identify what we call residual risk of cardiovascular disease. So in patients who may be very well treated with statin therapy, if they have high levels of lipoprotein little a, it does serve as a marker of increased risk. So it provides an assessment of an increased risk despite treatment with statins. Of course, we know that residual risk is a very wide term. It's not just related to lipoprotein little a. It can also be triglyceride-mediated risk. It can be risk that is mediated by inflammation, as we have seen. But lipoprotein little a also seems to be responsible for at least part of that residual risk that we see in statin-treated patients. In general, we say that about 30-35% of the cardiovascular disease events are reduced by statin therapy, but then we have 65-70% of the events that still persist. And those events can be explained by a lot of these parameters, and lipoprotein little a is one of them. Now, the question you asked was that how does it relate to other risk markers or risk factors like hsCRP, coronary artery calcium scores, like CAC scores? And the answer is that all of these things do add up. Some of these are risk markers. They may not be causally associated with atherosclerosis, but they're very good markers. Some of them are markers of showing you where atherosclerosis is. What Lp(a) brings to the table is, as I mentioned earlier, it's in the causal pathway of atherosclerosis. So it is additive in addition to the other risk markers or risk factors you may have. And there are some studies showing that it may provide further risk stratification on top of the traditional risk factors that we have. I think the next question, or perhaps that was your first question, which was, what kind of patient populations do we use it in? Now, that is where the guidelines do differ in terms of whether it should be measured in everybody, whether it should be selective. So I'll just give you a summary of where various guidelines are. Now, if you look at the 2018 American Heart Association, American College of Cardiology, multi-society cholesterol guidelines, they would mention that this could be measured in patients who have premature family history of cardiovascular disease, and if measured, then you use it as a risk enhancer. Now, if you look at the European guidelines from 2019, they mentioned that it should be, or clinicians should consider screening it at least once during lifetime. As I mentioned earlier, that the levels do remain fairly stable after early childhood because most of it is genetic. We do see some increase in women after menopause, but generally the levels are very stable. In addition, the European guidelines say that extreme elevation, which would be 180 milligrams per deciliter or 430 nanomoles per liter. Now, whenever you measure it, it comes in 2 units. You can either get a milligram per deciliter assay or nanomoles per liter assay, and we should talk about it a little bit later. But if you have very high levels of Lp(a), the European guidelines suggest that the risk may be as high as familial hypercholesterolemia. Then you have Canadian guidelines which say that once in lifetime screening should be performed in everyone. They are very strong in terms of recommending that. If you look at National Lipid Association, NLA, then NLA would suggest that it is reasonable that we use lipoprotein little a to refine risk assessment in patients who have personal history of premature ASCVD. So if you measure lipoprotein little a in young patients who are having MI or stroke or PAD, there's a good chance you'll find a fair number of them who have abnormal values. So that's one patient group where NLA recommends it. Second is first-degree relatives of those with premature ASCVD. And then those with severe hypercholesterolemia or FH. What we know is that high levels of lipoprotein little a actually can increase the proportion of FH diagnosis, because lipoprotein little a, when you do your usual lipid measurement, the cholesterol component of lipoprotein(a) is inserted into LDL cholesterol. So some patients that we may diagnose with FH may actually have very high Lp(a) cholesterol levels, and those levels are tagged along with LDL cholesterol, giving the impression of FH. But at the same time, patients with FH who have concomitant elevation of lipoprotein(a) have a much higher risk for the same LDL cholesterol compared to another patient who does not have high Lp(a). So it's a good practice to measure Lp(a) in patients with FH as well. And then there are some other groups where one could consider, for example, if you have progressive valvular aortic stenosis, where you cannot explain it, you may do it just to identify whether this risk may be driven by lipoprotein(a). And then, as I said, that patients who have borderline risk, intermediate risk, and you're looking for reasons whether they need to be started on therapies, for example, lifestyle therapy, statin therapy early on, one could use lipoprotein(a) levels as a risk enhancer to further identify high risk. So that is in nutshell where the guidelines stand. Some guidelines say once in lifetime. Some guidelines say patients who have personal history of premature atherosclerosis, premature cardiovascular disease, family history of premature cardiovascular disease, or since these levels are genetic, if you have a family member who has high levels of lipoprotein(a), then perhaps that cascade screening of other first-degree relatives is a very reasonable thing to do. And then, as I mentioned, FH is another patient population where elevated Lp(a) levels do provide further risk stratification in terms of identifying those who are at very, very high risk of having ASCVD events. So a very long answer to rather two short questions, Ankur, that you had.
No, this is exactly what I was looking for, and thank you for going over the details and the technicalities of causality versus association, and causality versus it being just a risk marker. That was very enlightening for me, personally, and then in terms of in what patient population do you order Lp(a), which can facilitate risk prediction and can, as you mentioned, serve as a risk enhancer for you to either accelerate primary prevention strategies, whether it's lifestyle or statin therapy, or even which is going to be my next question is, for example, in a patient in whom, let me back up here because I do have another question, and then this will be a follow-up one. For patients who come to your office and are asking you about Lp(a), what do you tell them in terms of how do you get this measured? Is this just a blood test? Do you request them to come fasting in the morning, or is it something that could be drawn at any point during the day? And how cumbersome or how easy it is for patients to get Lp(a) testing? That's the first question. And then the follow-up to that is in a patient in whom you think is at a heightened risk for atherosclerosis, either because of ethnicity or family history, in whom you think it's a good idea to get Lp(a) testing done, and you get the results back and your LDL levels are within the normal range and you have an elevated Lp(a). Is there anything right now that you do to intervene in such a patient? So those are my two questions.
Sure. So going to your first question, I think it's a great question. So patients need to know that there's no fasting that is required when one is measuring lipoprotein(a) levels. So that's for the patients. But for us as clinicians, it is one of those parameters where measurement has significant implications. What do I mean by that? So, I very briefly talked about the lipoprotein(a) being an LDL particle that is attached to a protein called apolipoprotein. Now, this protein, because of its structure, can have multiple residues of some units that can really play havoc as far as the measurement is concerned. So there are assays for lipoprotein(a), and that is one of the real issues with this field, that especially some of the earlier assays, and even now there are some assays that are very sensitive to the size of the isoform. So you have some small isoforms of lipoprotein little a, you have some large isoforms of lipoprotein little a because of these repeats of residues that I mentioned, just now. So you have to make sure that the assay you are using is isoform insensitive. Otherwise, you may be over or under measuring true Lp(a) levels based on whether you have a patient who has a predominance of large isoform sizes or small isoform sizes. So that's one thing that one should know. Now, in the United States and most of Europe, there are very good assays that are available which are isoform insensitive. When clinicians measure lipoprotein little a levels, usually the report comes as one of the two. Now, there is lipoprotein little a cholesterol level available as well. I would not recommend that. Let me repeat. I'm talking about cholesterol content of lipoprotein little a. That is not generally, that is something that's recommended. You should look at the overall lipoprotein little a levels, which includes the protein component, the cholesterol component, the phospholipid component, everything included. And that comes in two kinds of assays. One assay that gives you the answer in milligrams per deciliter, and then the second assay that gives you the answer in nanomoles per liter. So the nanomoles per liter or the molar assays, if you have access to those are much more reliable because they are much less sensitive to the isoform size. Milligrams per deciliter assay depends whether they have been calibrated or not very well calibrated. Now, there is a way to convert milligrams per deciliter to nanomoles per liter, but that is generally not recommended by any major guideline. So for clinicians, I think not to complicate this further, if you have access to a nanomoles per liter assay, then please use that assay. That assay is generally much more reliable and not as sensitive to the isoform size. And the repeats that, especially the repeats that we have in the Kringle repeats we have in this apolittle A protein. If you have a milligram per deciliter assay, make sure that it is a well-calibrated assay. And then the cutoffs for higher risk differ between the nanomoles per liter assay and the milligrams per deciliter assay. Generally speaking, as I said, first thing we should understand that the risk is continuous, but for our own sake, we generally all would like to say that above certain level, the risk is high. I think most guidelines at this point would say that above 50 milligrams per deciliter or above 125 nanomoles per liter, it is high risk. Those are patients who generally would carry a higher risk. I think that's very well known and most guidelines agree as far as that part is concerned. Less than 30 milligrams per deciliter or less than 75 nanomoles per liter is generally low risk. Between 30 to 50 is that area where the risk is there, but the risk is of course not as high as above 50 milligrams per deciliter. So when you're using when you're using a milligram per deciliter assay. So I think the way most people would look at it, if you have less than 30 milligrams per deciliter or less than 75 nanomoles per liter, that's generally a rule out. You are above 50 milligrams per deciliter or above 125 nanomoles per liter, generally that's a rule in. And then there's a gray zone between 30 to 50 milligrams per deciliter or 75 to 125 nanomoles per liter. Now, I would mention that, this is described really well in the most recent consensus statement that was published by European Atherosclerosis Society, which I had the pleasure of being part of that group. It was just published in the European Heart Journal, where a lot of these issues that I'm talking about are actually very well described, as well as one of the recent think tank meetings that was convened by the National Lipid Association. So a lot of these concepts are described there, but this concept of rule in, rule out, as well as gray zone is very well described in the consensus statement that was recently published by the European Atherosclerosis Society in European Heart Journal. So that's how we look at the access risk from lipoprotein little a in terms of rule in, rule out, gray zone. I wanted to talk a little bit about the assay, which I mentioned that we should use assays that are isoform insensitive. Generally speaking, nanomoles per liter assays are much more desirable if you can get those done where you are practicing. Now, then you asked the question, I believe, as to what do we do with high levels of lipoprotein. Was that the other question you had, Ankur?
Yes. So, once you found out that the LP little a is high, depending on what assay you've used and the cutoffs that you've used, and thanks for going over the thresholds with us. In a subset, I guess in a subset in which you have high LDL and LP little a is also high, you would start them on statin therapy and lifestyle modification, obviously. But in a subset in which your LDL is normal and the other parameters are within the normal range, and you have an elevated LP little a, based on the cutoffs that you just mentioned, what do you do in that patient population?
Yeah, that's a great question. So I would like to make a few comments first. First is that elevated LP(a) levels, unless you have extremely high elevated levels, which I talked about earlier, generally speaking, when you have elevated LP(a) levels, it's like any other risk factor, that the risk is in the context of global ASCVD risk. That's why I mentioned the words 10-year risk earlier as well, right? If you borderline risk, intermediate risk. So that risk is extremely important, because if I say that a parameter increases your risk, relative risk by 10%, 20%, well, that may not mean much if your absolute risk is very, very low, right? So that's why LP(a) measurement and its treatment is done in the context of global ASCVD risk assessment. So clinicians should do that first. That's the number one point. The second is that when you have high levels of LP(a), when we look at therapies, those should again be looked at in terms of global ASCVD risk. If somebody's baseline risk is, I'm just coming up with hypothetical numbers, is 10%, but because of elevated LP(a) levels, it goes up by 15%. Now we know that lifestyle therapy can lower your risk by 25, 30% or in excess of that. Well, the absolute risk reduction with lifestyle therapy that you will get in a person who does not have LP(a) elevation will be much lower compared to a person who has high levels of LP(a). So lifestyle becomes that much more important when you have multiple risk factors, when your 10-year risk is high. So I want to emphasize to clinicians that when you have high LP(a), don't forget your lifestyle. The same holds true in terms of blood pressure reduction, in terms of diabetes control. All those things become extremely important when you're trying to personalize treatment for a patient with lipoprotein(a). So those two things, in terms of lifestyle as well as control and measurement of other risk factors, is extremely important when we talk about lipoprotein(a). Now, once that's done, we can talk about therapies that are in that prevention space. So one of them is statin therapy, which I mentioned earlier. Now, when we talk about statin therapy, there is one meta-analysis that shows that the levels do go up. Another meta-analysis shows that they don't. But I think all of us agree that if your risk is high, don't worry about lipoprotein(a) levels staying stable or going up some. Go ahead and treat that patient with statin therapy. That's number one. After statin therapy, now we know niacin lowers lipoprotein(a) levels but does not reduce cardiovascular events. Of course, we have data related to hormone replacement therapy. We know that that is also not recommended in the overall scheme of things. So those two are out. But after that, we have PCSK9 inhibitors. And what we have seen with PCSK9 inhibitors is that 20 to 25% reduction in LP(a) levels is seen. Whether that is significant enough to lower ASCVD events remains to be seen, but there is good data that the reduction in ASCVD events that we see with PCSK9 inhibitors can be to some extent explained by a reduction in lipoprotein(a) levels. So that's another therapy that is available. Outside of that, apheresis, if you do apheresis, that will lower lipoprotein(a) levels very effectively. Generally speaking, that is something that is reserved for patients who have progressive ASCVD despite optimal treatment and very high Lp(a) levels. So that is not a therapy that we use very often. Now, the other therapy that clinicians will hear once in a while that I think is important to mention is aspirin. So there's some data from a women's health study early on, and just recently in the past couple of weeks, there was a sub-study from ESPRIT trial, which, as you would recall, was a trial done in older adults with aspirin therapy. Overall, the trial really did not show a net benefit of aspirin therapy, but a paper was published recently where the investigators showed that in those who have high risk genotypes associated with high levels of Lp(a) levels were not measured, but those genotypes that are associated with high levels of Lp(a), in those patients, there was a net benefit of aspirin therapy. Similar results were seen in women's health study as well. So, and then I mentioned earlier that you would remember that apo(a), the protein, has a very high structural homology with plasminogen. So by giving aspirin, low-dose aspirin therapy, are we able to mitigate some of the risk associated with high levels of Lp(a)? Now, we have some of these studies. These are either post hoc analyses or analyses that, of course, are open to confounding. But there is some data that aspirin therapy may have a net clinical benefit in those with high Lp(a). So high Lp(a) may be one such subset where we may find a role for aspirin therapy in primary prevention. And last but not the least, we actually have therapies that specifically lower lipoprotein levels up to 80% or so. So we have antisense oligonucleotides, which are single-stranded molecules that inhibit the messenger RNA for lipoprotein in the hepatocytes. Then we have another form of technology called small inhibiting RNAs, siRNAs, that also inhibit the messenger RNA for lipoprotein in the hepatocytes, and they are also very powerful agents in terms of lowering Lp(a) levels by a large amount. Question now is that do these agents, in addition to lowering lipoprotein, do they lower ASCVD events or not? And that is where there is a trial that is currently ongoing, the Horizon Lp(a) trial that is basically using a product called pelacarsen, which is an antisense oligonucleotide against lipoprotein(a), and the target population for this trial is patients in secondary prevention and those who are statin treated but have Lp(a) levels that are above 70 milligrams per deciliter. So fairly elevated Lp(a) levels, and it is trying to answer the question where lowering Lp(a) with pelacarsen reduces ASCVD events. It'll be a few years before we have the results of a Horizon trial, but I think it's something that will add much more and many more options for all of us in treating our patients if the results are positive. Of course, that remains to be seen whether that works or not. So in general, this is how one would look at it. But I would emphasize again that high Lp(a) levels, unless they are extremely, extremely high, Lp(a) levels should be made part of the global risk assessment, and they should be assessed in the context of global risk assessment. And when we're trying to treat Lp(a) levels, we should look at the patient globally and look at lifestyle therapy, look at statin therapy, and then we move on towards specific lowering of Lp(a), for which, as I mentioned, currently we do not have RCT evidence that lowering Lp(a) specifically lowers ASCVD events.
Yeah, no, excellent information. There's a lot to digest there. Let me, the one question I had for the secondary prevention trial that you mentioned was, is there a comparator arm looking at intervention with PCSK9 and versus antisense oligonucleotide, or is it antisense oligonucleotide versus, standard of care, which I would assume is just statin therapy in patients with secondary prevention?
Correct. So it is the later. The usual care is well-treated secondary prevention patients. And as you have seen in even the more recent PCSK9 trials, when you look at 4A trial or Odyssey outcomes trial, these are extremely well-treated secondary prevention patients. So these are, again, in Horizon Lp(a) study, the secondary prevention patients in usual care are extremely well treated, and they are compared against a group that is receiving the current standard of care, but they are in addition receiving pelacarsen.
Yeah, no, this has been just a power capsule of information for Lp(a), as to what it means and how to interpret the results, the values, and what to do in terms of targeted therapies and what is on the horizon. Pun intended there. The Horizon trial is actually underway. Any closing remarks on the discussion that we had, Dr. Virani, before I ask you, closing remarks about the podcast?
I think the message I have for clinicians is it is one of those particles that's been very difficult to understand. We still don't know everything about the biology, the synthesis, and how it's taken up by which cells, about this molecule. But there are some excellent resources that are out there with, again, I mentioned some of those, with the NLA think tank report, which is a short report, a recent article by the European Atherosclerosis Society. Of course, our ACCHA guidelines talk about lipoprotein(a) as well. Just take a look at those to familiarize yourself. You can still use it quite a bit for risk assessment, and as I talked about, therapies as well. And then, of course, stay tuned with the Horizon trial, and that will really tell us whether we need to specifically lower lipoprotein(a) level. So just stay tuned. There's a lot coming as far as this particular lipid molecule is concerned.
And your final closing remarks about Parallax. We are into season 4. We've recorded over 80 episodes, and it's been a journey for us. And throughout all of this, you've certainly been an incredible supporter of my career and my endeavors. And what is the message you have for the podcast and for the listeners?
I think as an educator myself, Ankur, being a cardiologist who works in an academic environment, I think what I have learned is that there are multiple types of learners. Some of us are very good. When we see patients, we just learn predominantly from that. Some learn very well by reading things, some review articles, some learn a lot by reading original investigations. Some of us learn really well by listening to podcasts. So I think, and then of course, a lot of us are folks who do a little bit of everything. So based on your learning style, I wanted to congratulate you on having a podcast that caters to a lot of clinicians who want to learn stuff. And these podcasts are extremely strong in terms of getting the message out. So wanted to thank you for the opportunity to use this format to get a few words out about lipoprotein(a), since this is one of those up and coming topics that I think most of us in preventive cardiology need to know about. And at the same time, I wanted to thank you for taking up this initiative and doing it for the greater clinician community in a way that it's easily digestible chunks of information that you can listen to wherever you are. You don't have to be, you don't have to open up a paper or a review article, but you can get these chunks of information while you may be driving, maybe taking a walk, or doing something else.
Yeah, thank you so much, Dr. Virani. It's always a delight and a pleasure to speak to you. Whether it's about my career, whether it's about Lp(a), or whether it's about life in general. Always cherish these conversations, and I'm honored and feel blessed that I am one of your mentees, and will continue to be so for the rest of my life. congratulations to you on a big role that's coming up for you in your career. And, again, couldn't have gone to a better person, and a clinician investigator and an educator. So, I'm sure you'll have your work and will have a lot of impact in populations who need it the most. Congrats on behalf of the team at Parallax. Really, congratulations on the role that you're going to take on with Aga Khan University.
No, thank you, Ankur. Definitely looking forward to some meaningful work with both medical and non-medical research, related to culture and media, as well as climate change. So very excited about the opportunity. As far as the podcast is concerned, the pleasure was all mine. You've done amazing work, and I hope that you'll continue to do such amazing work in the near future.
No, thanks again. And to the listeners, please rate us and review us on Apple Podcasts, SoundCloud, Spotify, Google Play, Audible, among other platforms that you use to download these episodes. Again, we're very grateful that you listen to us. And, we take feedback and remarks very seriously. And we try to get guests on the show, who you think are going to add value to your daily clinical practice and to your physician well-being, and to your professional life. So with that, thanks again, and we'll see you back another Monday.
We hope you enjoyed today's podcast, produced by Radcliffe Cardiology in association with makeadent.org. We aim to bring you a new angle of all things cardiology every second week. Review us on your favourite podcast app, or send your comments or questions to podcast@radcliffe-group.com. To view the series, head to radcliffecardiology.com/podcasts/Parallax. Thanks for listening.